Okay, so welcome to the CVS seminar. It's our second seminar, and we will immediately start with the questions, I think. So if you guys have any questions before, after, in between, you can just leave them in the chat. And let's start. Sorry, I'm gonna just mute you. Sorry. Okay, guys, the quiz started, so if you can answer.
Okay, so I see that majority of you got the cyanosis part right. In the first one, be careful because it's actually a reversal of a left to right shunt. So how I just talk a bit about how Eisenmenger syndrome works. So basically, you start off with a left to right shunt. Then over time, because you're passing on more blood to the right ventricle, and as a result, more blood is entering the pulmonary circulation, you end up having right ventricular hypertrophy, which is in response to the pulmonary hypertension. And as a result, the pressures in the right ventricle can start to exceed those in the left ventricle, and it turns into a right to left shunt. So it's wrong to say that it's a reversal of a right to left shunt. That's actually the final result of what is happening. Can occur in tetralogy of Fallot. Again, tetralogy of Fallot actually has not much to do with Eisenmenger syndrome, because how it starts off is that you have a right to left shunt because of like a bunch of the defects, which is like the right ventricular outward tract obstruction, the pulmonary stenosis, etc., and the VSD. So it doesn't really have much to do with this syndrome. As for cyanosis, yes, that's true, because because of the right to left shunt, you're mixing the deoxygenated blood from the right ventricle with the left ventricle, which is going to go to the rest of the body. And pressure in right ventricle greater than left ventricle, that's true as well, because that is the mechanism of the shunt reversal. Does anyone have any questions? Okay, if not, I think we can go to the next question. Okay. Oh, I see. The first one, it was a bit tricky. It was just one word in scripta, but basically, there's this drug called thalidomide. It's not prescribed for the morning sickness indications anymore. But when the company made it, they thought that it helped with nausea and stuff. So they started to prescribe it to pregnant women. But it turned out to be something that was teratogenic, meaning it causes like tons of deformations in children. So it was discontinued. Nowadays, it's used more for cancer treatment. So they're unlikely to ask you something like this, but it's good to like pay attention to stuff like that. So that's the reason why drugs treating morning sickness, they may cause congenital heart defects. Then I see the second one, all of you got it right. That's great. The reason it happens is because like obviously there's more blood entering the pulmonary artery because of the patent ductus arteriosus, and then As a result, increased blood in the lungs, so increased pressure, and it's causing pulmonary hypertension. And I see none of you picked the other two, which is good, because it's the opposite that's true in coarctation of aorta. You have BP in the lower limbs actually being lesser because distal to the point of coarctation, you're going to have hypoperfusion. And ASD does cause right ventricular hypertrophy, and the mechanism is similar to something that I explained in the previous question. So basically, more blood enters the right atrium, so there's more blood in the right ventricle, more blood being pumped to the heart, sorry, to the lung. And as a consequence of that, to match the increased pressure, the right ventricle starts to hypertrophy. Anyone have any questions? Okay, then I think we can go to the next one. Okay, so I see a good chunk of you picked the no correct answer option. So number one, valvular stenosis leading to dilation is not true because generally stenosis causes pressure overload, which is going to cause hypertrophy. So it's nice to see none of you picked that. As for aortic stenosis, so over here it's right up till the point where we say the reason is increased pressure in right ventricle, because the reason the edema starts to occur, basically you can imagine aortic stenosis is putting increased pressure on the left ventricle. The left ventricle starts to hypertrophy. And this also means that it's not as compliant as it was before. So the blood can start to sort of back up into the left atrium. And the increased volume of blood and the pressure combined, it starts to back up into the pulmonary veins and it makes its way back to the heart, causing pulmonary edema. So the right ventricle really doesn't have much to do with this specific set of events that we're talking about. Coming to the next one, again, if you do this, you might kill the person because someone who has aortic regurgitation, they might be in a sort of compensated state, and giving them a large infusion, it might be the sort of push that, causes an acute decompensation of the situation, and it could cause heart failure. So the right answer would be no correct answers. Any questions? Okay, we can go to the next one. Okay, so I see this one was a bit tricky as well. So acquired heart defects can be caused by streptococci, but not by streptococcal skin infection. And the reason for that is that how the heart damage basically occurs is because of molecular mimicry. So the streptococci, they have something called an M protein, and that resembles the proteins on cells within the heart, basically. So the strains that cause pharyngitis or like a throat infection, they tend to be more rheumatogenic because they express the right M protein. Whereas strains which are causing the skin infections, they tend to be less rheumatogenic and they're unlikely to cause like heart defects. But they can cause glomerulonephritis because that is mediated by like antigen antibody complex collection and it doesn't have much to do with molecular mimicry. So it wouldn't be true to say that. The second one, this is true because a previously damaged valve, the surface isn't smooth. It's going to promote like thrombi and stuff collecting on it, etc. So the biggest risk factor is a previously damaged valve for infectious endocarditis. As for the third one, everything is right up till the point that we say that the reason is because of transport of vegetation through lymph. That statement doesn't make much sense because imagine if you have some collection of septic like a vegetation whatever on the mitral valve. So now pieces of it can break off, enter the left ventricle, go to the body through arterial circulation. Or in the unlikely event that you have it on the tricuspid valve, then maybe it would enter the lungs. But the lymphatic system is not really involved in this, so it's either the venous or the arterial circulation. Does anyone have any questions? Okay then. So feel free to like drop it in the chat if you have any questions, and we will share the document with you later so you can review it as well. Thank you.
Okay, so for this question, it's about the relative insufficiency of coronary arteries. The first one, it is false because insufficiency of coronary arteries can either be absolute or relative. Usually, in absolute cases, there is a decreased perfusion, and in relative cases, the perfusion can be either increased or normal. For example, in hypertrophy of the left ventricle, that's a case of normal perfusion, but the metabolic demands of the heart has increased because of the hypertrophy. So the statement that it is always increased perfusion is incorrect because it can be either increased or normal perfusion, and is because of velocity of blood ejection. Well, I'm glad everyone did not select that. You would remember that if there is like sympathetic activation, there tends to be high velocity of the blood that is ejected from the heart. And this causes a suction effect at the aorta, which causes the valves to somewhat cover the orifice, which is where the blood goes to perfuse the coronary arteries. So in this case, there would be a decreased perfusion to the coronary arteries, so you would consider that more absolute than relative. As for the peripheral cyanosis, this is more common in, for example, heart failure, but in this case, we're talking about ischemia of the myocardium, so that would present more as stenocardia, which is the classical pain which is behind the sternum that radiates to the lower jaw, left side to the left arm. And it does also radiate to the epigastrium, but that is more in rare cases. So the last one should also be true. We can move on to the next one if there are no questions. Okay, good job, everyone. So the first one, REM sleep, is characterized by vasospastic angina. That's not true. The statement should actually be the other way around, where the vasospastic or the princemental angina, it's characteristically in the REM sleep stage. So pain can last for more than 20 minutes. That is not true. That is the case for myocardial infarction. Instead, pain should be for about like 3 to 5 minutes and should be relieved by nitrates. So people with chronic angina pectoris have higher chances of surviving MI. That is true because of the formation of collaterals, and during ischemia, the collaterals can continue to perfuse the muscle to prevent an infarction, which is the MI. Causes ST elevation on ECG, that's not true. ST elevation is actually like the STEMI, which is ST elevation associated with myocardial infarction. Instead, ischemia actually causes ST depression. Okay, so for hyperthyroidism, it's pretty straightforward that it causes positive tropic effects on the heart, and that can increase the metabolic demand of the heart, and that's why you can have insufficiency of coronary arteries, and it's usually considered to be a relative insufficiency. Can be treated by sympathomimetics. This would be worse for the patient because if you remember, this would cause the higher velocity of the like blood ejection, so lesser would be going to the coronary arteries once again. This would be somewhat of an absolute insufficiency. At the same time, it would increase the heart rate, so that's a decreased diastolic filling time or perfusion time for the coronary arteries, and because of that, you can consider it basically an absolute insufficiency. And then also, yes, I mentioned it would increase the metabolic demands, and that would consider it to be like relative insufficiency. So giving sympathetic mimetics is contraindicated. And basically, as I mentioned, the three effects of sympathetic activation, it's difficult to say entirely whether sympathetic activation can be absolute or relative. You cannot select only one of them. It's a mix of both absolute and relative.
Okay, so I'll be explaining the heart failure questions. So the first option, it is water retention because of RAS, but it's not hyperkalemia, it will be hypokalemia because aldosterone has a hypokalemic tendency. Is it primary polycythemia? No, because primary polycythemia is like a disease in the bone marrow, but rather what it is secondary polycythemia, meaning polycythemia that is because of some underlying condition, which is the third option. It's not primary polycythemia. And it's not decreased aldosterone, obviously, because aldosterone increases in heart failure pathogenesis, and intracranial hypertension has nothing to do with the pathogenesis of heart failure. Okay, so as for the first option, heart failure arising when a critical cardiac output is not met, that is not really true, or necessarily it's not true. And the reason is because heart failure is just a relative condition or a relative term when it doesn't meet the body's metabolic demands. So you can even have heart failure either with reduced ejection fraction or with not increase, sorry, preserved ejection fraction. So really there's no such thing as a critical cardiac output for it to go below. If systolic dysfunction has reduced ejection fraction below 30%, while this in theory might be correct, it's not really because the criteria for like reduced ejection fraction is 40% and you have to stick by the criterias. So it's not going to be 30%, it has to be 40%. Similarly, in diastolic dysfunction, ejection fraction has to be at least 50%, not 30. So glad no one went for that. And the most common cause of right heart failure is, in fact, left heart failure. Okay, so about this one, yes, polycythemia can be both a cause and part of compensation. It can be part of the cause because if you remember, polycythemia increases blood viscosity, and with increased blood viscosity, you have higher resistance, and with higher resistance, there's increased work of the heart. So if there's increased work of the heart, it can lead to heart failure, and it is in fact, one of the etiologies of heart failure. Polycythemia is again a part of the compensation because secondary polycythemia, well, it was explained before. Um, to further elaborate on secondary polycythemia being a compensation, it's that when there is some sort of left heart failure, there's hypoxia in the rest of the body. And for the body to sort of meet the oxygen demands, it has to increase, like it compensates by increasing the amount of red blood cells. So this is the action of uh, erythropoietin, EPO, that's released by the kidneys once there's hypoxia. Can be expected in a person with facial myxedema? No, that's not the case because that is a sign of hypothyroidism, but heart failure can arise instead in hyperthyroidism, which in Graves-Basedow disease, it can have pretibial myxedema. That's why I wrote the facial just to be more precise. Um, can be expected in a person with increased levels of vinyl mandelic acid in urine. Yes, that is the case. And what this basically indicates is that a person with pheochromocytoma, and in fact, a person with pheochromocytoma can develop heart failure because of like the increased demands or work of the heart by increased amount of catecholamines. And an acute form can progress to chronic form, and that is also true. An example that I can think about is, for example, after an episode of myocardial infarction, once that's treated, the acute heart failure progresses to a chronic form. Okay, so I'll tackle the options one by one because there seems to be quite a lot of them. So, in heart failure can arise metabolic acidosis and nocturia. I'm glad everyone went for these options. Metabolic acidosis because lactic acidosis is a result of the body's tissue ischemia, and nocturia because during the night the kidneys are better perfused. Because during the daytime, as the heart has like reduced ejection fraction in most cases of heart failure, the body sort of centralizes the circulation. So it attempts to increase the circulation of the heart, the brain, and also the skeletal muscles. So in this case, you're going to have reduced blood flow to the visceral organs, particularly the intestines and also the kidney. And that is why during the night there's compensatory increased blood flow to the kidneys, and therefore there's increased urine production at night. That is why people with heart failure have nocturia. As for paroxysmal nocturnal hemoglobinuria, this is not actually a sign of heart failure, but rather a complement system disease, so it has nothing to do with it. Decreased AMP levels, it's increased AMP levels because of increased atrial stretch. Sympathogenal activation, and this is beneficial. So this statement is partially true, but not entirely. So it does lead to sympathogenal activation, and that is what leads to centralization of the circulation. But this is not beneficial in the prognosis and the pathogenesis of heart failure because it would further worsen the prognosis or the development because the heart has already failed in the sense that the heart is already worn out. So if you just give a worn out organ even more tasks, then this will just make them wear out even more until eventual death, let's say. And in heart failure can arise peripheral edemas and hepatosplenomegaly. And yes, these are signs of, well, fluid buildup in the body because of right heart failure. All right, so left ventricular hypertrophy, it's not primarily caused by mitral stenosis. I mean, there is a chance that it can lead to it, but mitral stenosis primarily causes left atrial hypertrophy, and that causes like precapillary hypertension. That is something you will cover later. Develops an emphysema? No, and I'm glad no one went for it because in emphysema there is increased pulmonary pressure or pulmonary hypertension, and that would lead to right ventricular hypertrophy, not left. For Cushing syndrome, yes, left ventricular hypertrophy can happen in Cushing syndrome, and the reason is because in Cushing syndrome, essentially you have increased amounts of what's that? Glucocorticoids. So glucocorticoids, there are many functions of it, but two functions that I'm sort of referring to here is the mineralocorticoid action in excess amount of glucocorticoids. So that will increase the body water and sodium and therefore increase the pressure and like the systemic pressure. And the other effect is that glucocorticoids, they have a permissive effect on catecholamines. And when that happens, well, you're going to have excessive action of catecholamines. So both of these sort of contribute to increasing the blood pressure, meaning the systemic blood pressure, and that causes systemic hypertension, and therefore that leads to left ventricular hypertrophy as a compensatory mechanism. And left ventricular hypertrophy does not develop in tetralogy of Fallot because tetralogy of Fallot is a condition of, well, four deformities of the heart, and left ventricular hypertrophy isn't one of them. I believe it's right ventricular hypertrophy because there's pulmonic valve stenosis. It doesn't make sense for there to be a left ventricular hypertrophy instead.
توحيدة.
Wait, sorry. I was mute. My bad. Okay. Um, to repeat, concentric. I'm glad everyone got this correct. So this question was basically to differ between the concepts of concentric and eccentric hypertrophy. So concentric hypertrophy of the heart usually occurs when there is a pressure overload. So for example, in pulmonary or systemic hypertension. Whereas eccentric hypertrophy, well, there is a difference between the terms eccentric hypertrophy and dilation, but they're used relatively interchangeably. So I don't think it is the end of the world if you use them interchangeably either. But just, well, to differentiate between them, eccentric hypertrophy occurs when there's a compensation to a volume overload of the heart, whereas dilation particularly occurs when there is no time to compensate. So, for example, if there is a saddle embolus in the pulmonary vasculature, that would lead to a right ventricular dilation because there is no time for the right ventricle to sort of, how do I say, compensate by eccentric hypertrophy. Whereas in like congestion, it might lead to an eccentric hypertrophy because there is enough time for the heart to, well, compensate. Okay, so part of treatment of chronic heart failure was reduced ejection fraction. The cornerstones of this is lifestyle changes, and then beta blockers, ACE inhibitors, and mineralocorticoid antagonists. So the first option is definitely wrong because in adrenaline, you'd just be increasing the work of the heart. You don't give adrenaline in case of chronic heart failure with reduced ejection fraction. In fact, you give adrenaline in a person that has cardiac arrest because you want their heart to start beating again, but not to reduce, like, not in this case, basically. And as mentioned before, it's a cornerstone of the treatment of chronic HFrEF. So beta blockers are part of the treatment. Ensure the patient is always lying down in supine position. That isn't the case because in supine position, particularly in chronic heart failure, there's going to be some sort of congestion within the heart. And when there's congestion within the heart, you're going to have like backlog of the blood into the pulmonary circulation, and that would lead to something called pulmonary edemas. And well, that would cause the person to like wake up in the night gasping for air. So it's not really recommended to keep these patients in supine position, but it is better to like elevate them with like a few pillows so that it doesn't lead to like congestion within the lungs as well. So just restriction of sodium intake, yeah, that is true because, well, it's lifestyle change to reduce the blood pressure that decreases the work of the heart. Diuretics, it is part of the treatment because you want to reduce the amount of fluid within the body or congestion and decrease exercise. Um, that is actually like I know it's written there in scripta, like Kuba recommends that um, people with heart failure should not exercise much to reduce the workload of the heart. But in fact, like clinical guidelines show the opposite is true. And even if you search up like this heart failure on AMBOSS, you're going to see some light aerobic exercise is recommended in a person with chronic HFrEF. So am I challenging what's written in the scripta? Not necessarily, but I think like if such a question came up in the exam and you pulled up like Ambos or something in front of Kuba, he would eventually agree to like he would eventually agree that you don't want to reduce the amount of exercise in a HFrEF patient. Well, okay. It doesn't look like this needs much explaining because everyone has got the correct answers. Um, yes, it does develop as a decompensation. It's there in the question about the heart failure decompensatory mechanisms. It doesn't compensate aortic stenosis immediately because the compensation for aortic stenosis is LV hypertrophy, because in aortic stenosis, you're going to have a pressure overload, not a volume overload. And the volume overload is what's compensated by LV dilation. Aortic regurgitation, yes, because there's fluid backlog into the left ventricles. So yes, you're right. It is like LV dilation, aortic regurgitation, and C, like sorry, the option D sort of correlates to option B, which is that they both are pressure overloads of the heart, so they wouldn't lead to LV dilation, but rather hypertrophy. And yeah, LV dilation can't be caused by acute pulmonary embolism that causes right ventricular dilation.
Okay, so complications of myocardial infarction. So cardiac tamponade. Does anyone know how cardiac tamponade happens as a complication of myocardial infarction? Like what precipitates cardiac tamponade?
Like hemopericardium?
Yeah, hemopericardium. It's cardiac tamponade. Do you know how does it happen?
When
Are
an
you guys aware?
aneurysm ruptures or something in the heart?
Exactly.
And in the
Yeah. When an or the wall of the aneurysm ruptures. Other mechanical complications of myocardial infarction of the same sort is rupture of the septum, so it causes like ventricular septal defect, and there could also be rupture of the papillary muscles, which causes mitral regurgitation, which is the last option. Also, you can have increased thrombus formation. So, because in myocardial infarction, it's a inflammation and tissue damage. So you expect the release of like some tissue factors, some cytokines, and these all activate the coagulation cascade, as well as there could be some endothelial dysfunction and in general like stasis of the blood. And all these factors contribute to the formation of thrombus. So you have to give anticoagulation therapy. Other complications of myocardial infarction like can include pericarditis, Dressler syndrome, which is like delayed immunological pericarditis, cardiogenic shock, left ventricular failure, and pulmonary edema. And the second option here is atrial fibrillation, which is the most common, like frequent cause of death, is wrong. Do you guys know what's the most frequent cause of death after, like, because of like myocardial infarction? It's an arrhythmia as well, but it's not atrial fibrillation. Yeah, yeah.
Ventricular?
If Yeah, ventricular fibrillation, exactly, is frequent cause of this death. Atrial fibrillation can happen, but usually there are medications to control it, and as well as bradycardia, which can be dangerous if it's like very low, causing like decreased like cardiac output. And here I have for you guys like complications of myocardial infarction. I think this is good because you'll be asked about this in uh, pathanatomy, pathophysiology, internal this so much. So I think like in the first 24 hours, you expect the arrhythmia and acute heart failure, even cardiogenic shock. Usually we say when like 40% of the left ventricle is infarcted, cardiogenic shock occurs. And then from 1 to 3 days, yes, you expect like the pericarditis. And like after that, all of the mechanical complications, which is like, as we said, the rupture of the septum with ventricular septal defect, rupture of the papillary muscles with mitral regurgitation, or rupture of the free wall and aneurysms with increased like tendency for like thrombosis in the wall. And yeah, these are mainly the complications of myocardial infarction. So remember the arrhythmia, the mechanical complications, and the increased thrombus formation. So next question. Okay, so you guys got it correct, but let's just go through it quickly. So myocardial infarction, myoglobin is specific for myocardial infarction is not correct. Myoglobin is not specific. It's found in all muscles. So any muscular injury can cause myoglobin to increase. A more specific marker for myocardial infarction is what? If anyone can tell me. What is a more specific indicator of myocardial infarction? What do we measure?
Was it troponin C or something? Troponin I don't know. صح?
Exactly. Troponin I. So if you guys remember this graph from biochemistry, is okay. So you can use troponin. There's myoglobin. There's lactate dehydrogenase, and creatinine kinase. And while troponin is not immediately elevated and other stuff are elevated, usually troponin lasts the longest. So you can see in the graph it lasts even for weeks after the myocardial infarction. So we consider it a more specific indicator of myocardial infarction. Of course, like the most accurate way to diagnose a myocardial infarction would be like coronary angiography with like therapeutic PCI, but like while we're waiting for coronary angiography, you can do the blood test. Can result in cardiogenic shock. Yes, we talked about it. It's a complication. Usually it's a very fatal complication, can be the cause of death in like the first few hours after a myocardial infarction. And is a state of metabolic alkalosis is wrong, because in myocardial infarction, it's like the cells are suffering from hypoxia. So you expect anaerobic glycolysis with lactic acidosis. And also with the death of the cells, there's release of potassium, release of H plus from the cell. So all of this is a state of metabolic acidosis, not alkalosis. And the most common cause is not vasospasm, it's thrombus. Usually there's an atherosclerotic plaque, and usually when the atherosclerotic plaque ruptures, it exposes the thrombogenic materials in the center of the plaque, which formation and rapid occlusion of the arteries and myocardial infarction. So if there are no questions for this, if you do have a question, you can write it or like you can open your mic, but we'll move on to the last question. So let's go through this. So myocardial infarction, among its treatments are beta blockers. Yes, because it decreases the heart rate, so it decreases like the load on the heart, and it's overall better for like the recovery of the heart. Other treatments of myocardial infarction, this is not the main, like not the main treatment for the occlusion itself. For the occlusion itself, you need like thrombolytics, or as we said, PCI with like balloon stenting. But other medical treatments that help with the patient's survival include like, one second, yes. So it includes this abbreviation, MONA-DAS, which is like morphine, oxygen, nitroglycerine, aspirin, which is like an antiplatelet drug, thrombolytics, anticoagulants, softeners, which I don't think you need to know, but this is just for like to prevent them from like straining and possibly causing another cardiac arrest, and sedatives. But I think what you need to remember is like the MONA, so the morphine for analgesics for the pain, oxygen just to make sure the saturation of oxygen is in acceptable range, nitroglycerine, which is like vasodilator, and aspirin for like the thrombus formation. So all of this is for the myocardial infarction. So acutely can manifest on the ECG as Q waves. Myocardial infarction acutely manifests on the ECG as ST elevations. Sometimes there is like a type of myocardial infarction that we call NSTEMI, which is like non-ST elevation. But for now, I think you need to know that, okay, myocardial infarction we associated with ST elevation, and usually on the ECG, depending on the leads, you can figure out the location of the occlusion and the necrosis. So ST elevation, and chronically it's Q wave. And ECG changes are immediately like visible is not correct. Usually it takes at least a few hours for it to appear on the ECG. And I mean, yeah, myocardial infarction necrosis usually after 20 minutes. If it's before 20 minutes, you suspect some kind of angina pectoris, maybe even unstable angina pectoris. But if it's after 20 minutes, you can be sure that it's necrosis and myocardial infarction, and you have to treat it accordingly. So I think that's all. Congratulations to everyone here. Do you guys have any questions? So if not, thank you guys for attending.